Hey, everybody, this is Tom Sega from Duluth Pack, and this is Duluth Pack's podcast, Leader of the Pack. And today we have a really special guest and a friend of mine, Dr. Mike King, Cardiothoracic Surgeon. Mike, welcome.
No, thanks, Tom. Thanks for having me.
We're going to have some fun today, folks, and we're going to learn about a business that is very different than what many of us consider day-to-day business. And I've been lucky enough to know Dr. King for a lot of years and been able to ask him a lot of questions because I'm very intrigued about his career and what he does for a living because it's so different. You know, I always tell Dr. King, I always tell our employees that what we do here really matters and it's important to us, but we're not saving lives. We're not doing heart surgery. And I use that all the time. Well, you do. So, Mike, tell us a little bit of background on yourself. On where did you grow up and where did you go to high school?
So, Tom, I grew up in the Deep South. I grew up in Memphis, Tennessee, home of the blues, Elvis Presley, B.B. King. That's where I grew up at. And I went to a high school, Messick High School, which shows my age is no longer there. It's been subsequently torn down. But I grew up in Memphis and went to high school there and actually went to college and medical school both in Memphis. So I have a lot of deep Memphis roots.
And we can tell a little bit by the accent. You know, you lived in Minnesota a long time, Doc, but some things you just can't kick them all to the curb.
That's true. That's true.
Did you know in high school, or was it in college, that you wanted to go into the medical profession?
Actually, Tom, in all seriousness, I really felt a calling by the Lord, really, when I was 7 years of age. Despite a pretty dysfunctional family that I grew up in, I just really felt the Lord calling to me to go into medicine. And, it seemed like such a far, unattainable reach for all those years. I grew up very poor. And as I mentioned, my family was pretty dysfunctional. My father was I'm not ashamed of it necessarily, and nor am I proud of it, but his addiction to alcohol was pretty bad. And I think that my self-esteem in general as a little boy was quite poor. And I think that when I was 7, God just called to me and said, I have a purpose for your life. And I felt that calling. And really, Tom, it seems so, corny, but ever since I was 7, that's all I ever wanted to do. Be a doctor.
So you knew that you wanted to go into the medical profession is in grade school, high school. Were you strong in the sciences?
Tom, once you get self-esteem, I could go to school and read the textbooks and study, and I could make good grades. And that was my form of self-esteem. I wasn't a good athlete, I was kind of just a so-so musician, but I could make good grades. And so it was just my avenue to really, to kind of survive a pretty, like I said, tough upbringing. And it also led me in the direction of where it was, I couldn't understand what it takes to get to that point. That is to get into medical school. You have to make good grades. You have to study hard, apply yourself. So it became a pretty natural thing after a while.
So your undergraduate, what was that in if you knew that your focus and your tunnel vision to get into med school?
Well, when I finished high school, or actually several months before I finished high school, I thought I would just kind of, go to undergraduate school. I didn't have a lot of money. I had to borrow, the money to go to college. But at that time, I wasn't in a real hurry until one day in the mail, Tom, I received a little note from the government, the conscription service, which said, basically, you have a low number and you might be thinking about going over to Vietnam and serving, your country. And that was a pretty sobering experience to open up that letter. And so I went down to the draft board, took the physical, and this is like 2 months before I was going to graduate from high school. And I talked to the recruiter and I said, what is the chances of me not having to go to Vietnam? And Both of those guys, they laughed at me and they said, "Are you kidding, man? You're going to enjoy it. Really, we really appreciate your service to this country." And I said, "Well, is there any way that I might possibly be able to, to go in another direction because I really want to go to medical school eventually?" And they said, "Well, I don't know. Maybe if you had a student deferment, maybe if you went, if you were in school at the time." So I'm telling you, Tom, I graduated on Friday evening from high school. Monday morning, I was in summer school in college, and I guess I worked because I never, I didn't have to serve. I kind of regret, in a sense. I have deepest respect for veterans and people who have given the ultimate sacrifice, many of them, for this country. But that was the path I chose, to go right from high school right into summer school, and then thought, well, I better really study hard, and work hard. So I went straight through 3 years and got 2 majors in chemistry and biology, and then minored in English with intention of then applying to medical school.
So you jump in head over heels into college right away, when a lot of us, to be honest, really didn't have a clue when we go into college with, hey, I don't know what I really want to do when I grow up. You really knew what you wanted to do. So you get through with college in 3 years, you go into the sciences, you apply to med school, and you get into med school also down in the Memphis area.
I did. I went, once again, I didn't have a lot of funds or anything, and money. I was borrowing money to go to college, and then subsequently I needed to stay local just because the tuition would be less. So I went to the University of Tennessee, which was also their campuses in Memphis, Tennessee. So I went straight from, finishing my undergraduate degree, thinking I would go right to medical school. But the Lord had different plans for me, because I applied, Tom, late, to medical school. So, I worked so hard to get through in 3 years, thinking that I would just walk right into medical school. And then they said, "Well, too bad, but you applied beyond the deadline, for this next entering class." So I basically had a year to kill.
Okay.
And I asked the Lord, well, what purpose is this? I mean, why did I work so hard 3 years if I could have just done it in 4 years? I said, now I have to, take a year off, in a sense. So I applied, but during that year, I had several jobs. I began as a janitor in surgery. Then I became an attendant in the recovery room, taking patients back and forth to the rooms. Then I became a scrub assistant, basically someone who would hold retractors while the surgeons would open up the body cavities to do their procedures. And then one day, strange enough, well, maybe not so strange, because God works in mysterious ways, but I met a cardiac surgeon down in Memphis, and he said, "Listen, you've been around here for several months, and I wonder if we could entice you to work for us." And I'm thinking, absolutely, what do you need me to do, And he said, "Well, we're doing this new procedure. It's called coronary artery bypass surgery, coronary artery bypass surgery. And what we do, Mike, is that we take the vein, the saphenous vein, out of the leg, and we basically sew that onto the heart, past the blockage in the arteries of the heart muscle." And once again, Tom, I've got a college degree. That's it, So no formal training, I wasn't a nurse, nothing like that. So he said, "We'll train you, don't worry," and they did. And so for several months, I worked with the cardiac surgeons in Memphis, harvesting the vein and helping them do these procedures, coronary bypass surgery, which at that time was huge. Finally, there was a way to treat blocked arteries and prevent people from having heart attacks or dealing with their chest pain. And they were just so busy, 2, 3, 4 cases a day. And it was a great experience for me. And his name was Brister Harrington. He was a huge mentor and guy in my life that made such an impact. And he encouraged me when I finished working for them, and I was then, accepted to medical school. He said, "What are you going to do when you finish medical school?" And I said, "Well, I guess I want to finish medical school first." And then I said, "I'll probably do something in surgery." And he said, "Well, what kind of surgery are you going to do?" And I said, "I'll probably do general surgery, take gallbladders out, colon resections, something like that." And he got angry at me. He really got angry at me. And he said, "What are you talking about? You need to go into a cardiac surgery. You need to be a cardiac surgeon. Come back and join our group. We'd love to have you. Forget that general surgery stuff."
Well, thank gosh for that you have mentors out there that could push us in directions maybe we wouldn't have ended up.
True. Totally.
So,
Totally.
so you go to med school then, and you have your mentor telling you, "Hey, here's the deal. You're going to go to med school, but then there's some specialties. And by the way, I'm not asking you. I'm telling you, this is the direction we need you to
Oh, yeah.
go."
Yeah, absolutely. Yeah. No, he just basically just offered me a job. I mean, I hadn't even finished, medical school yet. But he wanted me to come back and join their group and be part of their group in this. And that was, I thought that was very kind and considerate and affirming to me. So I appreciate that.
So you go to 4 years of med school, and then you have to go further schooling, obviously, for your specialties.
Yeah, so back then, Tom, there was, in order to be a cardiothoracic surgeon, you had to become a general surgeon first. So the general surgery programs were 5 years, and then the cardiac surgical programs were either 2 or 3 years. So once again, this gentleman down in Memphis, he was very instructive about where I should go. I said, well, where do you think I should do my residency post medical school? And he said, well, if you want to be a heart surgeon, which you should do, there's only one place that you should go. You should go to Minnesota. And I said, Minnesota. Wait a minute. I'm from the South. Mason-Dixon line. It's cold up there. They have this entity. It's called snow and ice. I'm not really into snow and ice,
But it's
He
only
said, don't worry about it.
only 8 months a year, right?
Yeah, 8 months, yeah. He said, well, you should go to the Mayo Clinic. And I told him, I said, well, Dr. Harrington, I'm just a poor guy from the South, I don't know anyone up north. He said, well, let me tell you what you do. Go up there, spend 6 weeks during the summer of your last year of medical school. I get to know them. And if it works out well, the chemistry, then apply and hopefully you can do your residency there. So that was my connection to Minnesota. Once again, for his leading and his really encouragement to seek what he considered the very best place to train for cardiothoracic surgery at that time, which is Rochester, Minnesota.
So, Mike, how many years of school and residency does this all add up to then?
Well, if you take the 4 years of undergraduate, or excuse me, the 3 years of undergraduate and the 4 years of medical school, then another 5 years of general surgery, and then the other 3 years of cardiac surgery, you put all that together, that's 15, 16 years.
Holy catfish. Okay. Well, you know what? Here's what I'll tell you is whoever works on my heart, if anyone ever has to, I want them to have a lot of schooling. So now you're at the Mayo, correct?
Yes.
And you're doing, how long were you at the Mayo?
I was actually there 10 years, a total of 10 years.
10 years. And so at that point, you are a cardiothoracic surgeon.
Correct.
Okay. And then you get into private practice.
Correct. So at Mayo at that time, they really weren't doing any transplant surgery and heart transplant surgery. And there was a gentleman here in Minneapolis. His name was Dr. Lyle Joyce. And he actually encouraged me. He contacted me and he said, we have a group in town. We work mainly at Abbott Northwestern Hospital, but we also work at North Memorial and some of the other hospitals. And we have a transplant program. And we actually are also starting an artificial heart program. So I came up to the Twin Cities, Peggy and I did, my wife. We met Dr. Joyce and his family and Dr. Ills and Dr. Kaiser, and it just seemed like a good fit. And so we traveled, the 70 miles or whatever from Rochester up to Minneapolis, joined that group. And I practiced in that group for about 15 years before I became an employed cardiothoracic surgeon here at North Memorial.
So can you tell us a little bit more about when you were doing transplants? What goes into a heart transplant?
Well, I think the lay public thinks that, oh, this is just such a very, very tedious, difficult, stressful procedure. But the truth of the matter is doing a heart transplant is not that difficult. It's using large sutures. It's a pretty easy operation. It's more technically, taxing to do very fine coronary artery bypass work, frankly, than it is doing a heart transplant. But it's also very, very rewarding. Those transplant patients are so terribly sick by the time that they actually, receive their heart transplant. And to see them the next day or the day after they have a new heart, I mean, it's like, this is a new person. Their color changes. They go from ashen and gray to actually pink and viable. And it's just, it was a very, very rewarding procedure.
So I know when I've talked to you about this in the past, and I've questioned you, and we've been around each other. Sometimes I would guess probably to nauseum, because what you do is so different than what the realm of my life is. That you also have teams. I believe if I remember correctly, you have a team when it comes to transplants that actually gets the organ or organs, and then you have a team that then puts the organs in the transplant patient.
That's correct, Tom. So we have two teams. One is the harvesting team, which I would do that on occasion. And then the other times I would be involved with actually putting the heart into the recipient,
Does that have to do with timing?
It really became a matter of availability, because back when I was doing transplants with Dr. Joyce and Dr. Hills, Dr. Emery, others down at Abbott, it was a matter of who was available to go and either retrieve the heart, and then who's available to actually do the implantation, or to actually sew the heart into the recipient. So it just depends on what you were doing the next day. If you were loaded up with doing 2 or 3 elective cases, that's not the best thing to stay up all night going to either to harvest the heart or to put in into the recipient. So it's became who was available. And I had some really excellent mentors, Dr. Joyce, Dr. Ills, Dr. Emery. They're great guys, because I really didn't do any of that down at Mayo. That just hadn't really started yet. And so they kind of took me under their wing and taught me the ropes, and that program continues, of course, down at Abbott today.
Dr. King, you had mentioned also about artificial at that time. Was that like the old Barney Clark days? That I was thinking, and it popped in my head, the Barney Clark days. So did that ever get traction, or was it just found that? Help us out with that a little bit.
I think it did. It certainly got traction. Dr. Joyce was the one who actually implanted with Dr. DeReeves the artificial heart in Barney Clark in Utah. And when Lyle came to the Twin Cities, it was his hope and intention to bring that technology to Abbott. And he did. And he and Dr. Emery and others were involved. Dr. Joyce was the main leader in the Jarvik heart, the artificial heart there at Abbott. But I think it became pretty obvious to everyone that you needed such a huge number of additional bodies, physicians and nurses and everything. You can't just do coronary bypass or valve replacements. And by the way, you're doing transplants also. You need a dedicated team, dedicated cardiologists, dedicated cardiothoracic surgeons. And I think that was the beauty that the university and Mayo have. They have people who pretty much specialize in that. And now Abbott does too, I believe. But at that time, everyone did a little bit of everything. That was just part of the gig.
Tell us a little bit about the typical day of a cardiothoracic surgeon.
Well, it's changed a lot, Tom, over the years. It really has. I think that, as I mentioned earlier, in my, growing up years, so to speak, when I was being mentored by Dr. Harrington, for example, coronary bypass was just, there weren't enough hours in the day to do all the cases, and there weren't enough cardiothoracic surgeons. The programs around the country the competition was so steep to get into a cardiac training program, because there was so much work. There were so many patients that needed the services. And so the programs were going gangbuster, trying to graduate 2 or 3 applicants or fellows per year. And what changed, though, Tom, is that when interventional cardiology, the cardiologist, developed angioplasty, where they could go in with a balloon and open up the blocked artery, and then subsequently that transitioned to actually putting stents in, then the heyday of coronary artery bypass surgery had come, and I don't say it's gone, but certainly there was more selective, and there were less patients that went direct to the surgery and more patients that received stents. And then when drug-eluting stents came on the front, once again, less and less patients that the cardiothoracic surgeon would be asked to see for bypass surgery.
So what is a drug-eluting stent?
So a stent is like the inside of a ballpoint pen, basically, a metal type of cage, and it's impregnated with and coated with certain drugs which promote or prevent clots and fibrosis and scar tissue from forming within the wire cage, and that is those wonderful ideas, a novel idea, and the drug-eluting stents stay open longer than a stent that just doesn't have any drug impregnated into it. And so the cardiologist most of the time will not use bare metal stents. That is without the coating. They're generally putting coated stents these days.
Okay, so that is the cardiologists do the stents in like a cath lab, and then you stick more to the more invasive cardiothoracic surgery.
Yeah, I think, Tom, that these days the interventional cardiologists are pretty aggressive, in most places, certainly in Minnesota in general. And I think that if they have the ability to put one or two or sometimes more stents in someone, they'll do that first. And then they'll call the cardiothoracic surgeon only if they just find it technically impossible to place the stents, or if a patient's had stents in the past and they begin to close up or block off in time, then they'll enlist the help of the cardiothoracic surgeon to offer the patient conventional bypass surgery.
Okay, so what would a typical day, if there is such, for you?
Well, in the past, my typical day was I would get up at 6, I'll roll into the hospital about 6:30, and several years ago I was doing 2 or 3 bypass operations or valve replacements per day. So my typical week would be probably doing somewhere between 12 to 15 heart surgeries during that week, and then taking call, every other weekend or every third weekend, depending on how the coverage was at. So several years ago, I was very busy, and you had to be pretty efficient just to get that kind of workload done. And what changed is that with the stents, and especially the drug-eluting stents, there are less patients that are being filtered to the cardiothoracic surgeon. So my days, like for example, this week, you may have 1 or 2 cases to do, but nothing like the 15 or so that you did before. So I think it's much better lifestyle, but the volume is just not the same.
We're late in the day today. It's 3:30. So how did your day go today so far?
Oh, today was a great day. You saw some patients upstairs that had operated in the past. And I was just kind of talking to my colleagues and talking about some cases that were actually operated on today. And then I'm at 3:00. I wanted to come, chat with you, on this podcast. So it's been a pretty straightforward, pretty easy day.
So no surgeries for you today?
Well, not today. Yesterday I was on call. I'm on call tomorrow, and you just never know what's going to come through. The problem about being on call is that you don't know what's going to come either through the emergency room or what's going to happen in the cath lab, because there certainly are patients that go to the cath lab. The cardiologist cannot open up the blocked arteries, and you're either asked emergently to operate them or schedule it sometime in the near future. COVID has changed things a lot.
If you could sum it up, is like the fulfilling part of, you see a patient and obviously they're very ill and they need to have open heart surgery, and then you see this patient again afterwards. How fulfilling is that?
I think that's a great point, Tom. I think as surgeons, we tend to be very narrow-minded in the sense that we think of the patient going to the operating room, having the procedure, and then them going home and the operation's over. But that's really not the truth. The operation is not over until 2 or 3 months later, when they come back into your office and saying, "Doc, thanks so much. I've healed up, my incisions are fine, and I don't have that chest pain, or I don't have that shortness of breath, or whatever brought them initially in for their evaluation." That's what's very fulfilling and rewarding. Yeah.
So what's the most challenging part of being in such a specialty of cardiothoracic surgeon? And as I've done some research for this, I want to ask a few questions as we come up here too, because there's cardio, but then there's also thoracic. And I know those mean two very different things, but what's the most challenging part of what you do for a living?
I think the most challenging part, Tom, is the judgment that needs to go into seeing every patient. I think that as doctors, you graduate from medical school, they call you doctor. You get an MD, medical doctor. But a medical doctor is not the same thing as a physician. And to be a physician, that takes years of experience, and it takes learning judgment. So I think the most challenging part of my day, many times, is deciding not necessarily who to operate on, but who's not going to benefit from an operation. It's like going to the hardware store. If you're a carpenter and you go to the hardware store and you buy a hammer, good chance you're going to use the hammer. And I think that as a cardiothoracic surgeon or any type of surgeon, the best surgeons in my mind are the ones who not necessarily know how or where to operate, but they know when to not operate. So it's the judgment is really the challenge. Who's going to really benefit? Anybody can learn how to operate. I mean, it's a technical skill, Tom. It's not like something that only a few people could be, were chosen to do. I think that it's a technical skill, but it's really the judgment that goes in deciding who's going to really benefit, and are the risks worth taking for the potential benefit to the patient. That's also the most fun. It's the most challenging, but that's also the most rewarding, the most fun.
And that a lot of that must come with a lot of experience and a lot of wisdom that you gain from doing what you've done for so many years.
I think so, Tom. I think I'm at my top of my game right now at 69 from the standpoint of wisdom and judgment. And it just takes 7,000 operations probably to figure that out. But I mean, I think I look at things a lot different than I did, for example, the first few years that I got out of my training program. I think as a young surgeon, you're just trying to learn the ins and outs of operating independently, without somebody across the table telling you what to do, where to put a stitch. So you tend to be pretty aggressive, and you tend to think that, hey, you can take on anyone, anyone's problem, and you can, it'll turn out well for them. And I think, medicine and surgery is humbling, and you realize that despite all your best efforts, sometimes the patient won't have a good outcome. And I think that, there's two ways to look at that. One is to just say, well, that was a bad case. The other is to say, well, maybe my judgment was flawed. Maybe that patient really wasn't a good candidate to have that, shall we say, pretty, radical or, aggressive approach surgically that we took. Sometimes you have no choice, but in life and death matters. But it's the ones where you look back and you say, I wish I could have that one back, that second pitch, you know what I mean?
Sure. I don't know if people caught what you said there, but one of the things you said, and I don't know if this is the total number or that you said this is when you gain that wisdom, but you said 7,000. I don't know if people heard that. Somebody who's done 7,000 open heart surgeries. Well, I can tell you, if my heart ever goes bad, I have your phone number and I know who I'm calling, because I want the guy who's done a lot of them. I'm definitely if I get there, I'm going to say, this isn't your first day, is it?
No. Well, at Mayo, before I left, I'd done 1,000. So, it was, those were two very busy years. And the two last years when I was there. And of course, you've been in practice. I've been in practice up here 34 years. So and we were really busy at one time. But it's been a lot of cases, but it's been very rewarding.
No,
I wouldn't change it for anything.
Well, I want somebody like you, and I think you're cutting yourself way short when you say it's the technical skills, and anybody could do the technical skills. I would have to respectfully disagree with that, because you don't want old Tom here operating on your heart. I don't care how many times I've tried it. Let's talk about a different subject, because I as I was getting ready to do this interview today for the podcast, one of the things is I was thinking, if I had to have an open heart surgery, I'm going to have a lot of emotional things going on as well, and a lot of fears going on, because as experienced of a surgeon as you are, it's still my heart that needs to be fixed and worked on, and this is pretty serious business. How do you deal with the patients from the standpoint of their emotional strife that they're going through, and some of the fears that they're obviously going to have?
Well, I think, Tom, we take an oath when you're in medical school, when you graduate, to treat pain and suffering. And, but you don't take an oath to give someone immortality. And I think that part of all that is that you need to be able to walk in the patient's shoes. You need to be able to look the patient across the table or the chair in another chair and feel that same anxiety and emotion and suffering that they have. And I think those are the great physicians. If you can attain that, then I think you've reached a level that is pretty high, because I think it's so much easier to just take the denial approach, or just say, well, I'm going to go in there and do a job. We're going to do a valve replacement or transplant your heart or whatever we're going to do. And I don't want to deal with the emotions behind all that, because, I have to keep going as a surgeon. So if I get too involved with your emotions, it's going to affect me. But I look at it differently. I look at it like, it's really a ministry that we're trying to provide. I mean, physical as well as a spiritual and emotional healing for the patient. And I don't think you can do the latter two unless you're willing to, put yourself in a vulnerable position and actually empathize with the patient and walk in their shoes.
So you invest yourself right with them and feel that with them. That's amazing, because that's the complete package, if you ask me, and I'm very wowed by it. Can we talk about some equipment? Let's talk about earlier in your career, some of the equipment that you had to work with and technology that you had to work with, Dr. King, and then let's talk about today on some of the technology and the equipment there is. I'm assuming there's been some changes over the years.
Yes, I think, Tom, the heart-lung machine and the basic setup hasn't really changed a lot over the years. There've been some tweaks here and there, but it's basically the heart-lung machine per se is the basic design, and the function is pretty much been consistent throughout the years. But what's changed so much, I think, is the fact that now some of these procedures can be done with smaller incisions because the equipment is so much better. Some of these procedures can be done without using the heart-lung machine at all. And also something that used to be pretty much the bread and butter of what a cardiac surgeon would do, which is a valve replacement or a valve repair, is now being tackled by the interventional cardiologist, in the cath lab. So valves are being placed through the groin. I mean, an entire valve is being implanted into your heart through the groin. No incisions, no nothing. And clips are being placed on the mitral valve. That someone who has a leaky mitral valve, now some places they clip the valve. And of course, if you're the patient, you can just imagine if someone offered you a procedure that doesn't involve entering your body cavity without a major operation. Obviously, it's going to be very appealing to the patient. And so I think technology has really changed in being able to offer patients those alternatives these days.
Does the patient get that alternative on, I would like to have this versus that done, or is it usually on the recommendation of you, the surgeon, or the cardiologist together?
Well, I think everybody plays it differently, but when I see a patient, I go through all the different options. And one of the options, of course, Tom, is to do nothing, do nothing, or medical treatment, which is generally not very satisfying, but I mean, it is an option. And then I amp it up from there. Well, if you want to talk about, here are the surgical options. And some of those are invasive, like something I would do, like opening the breastbone or going between the ribs or whatever to do a procedure. But some of them are, maybe one of the interventional cardiologists would be willing to place a valve through the groin or to put a clip on your mitral valve or whatever. And the patients are very savvy these days. I mean, Dr. Google he's a very famous man.
Oh, we all, you know what? I think we all got our medical degrees through Google, didn't we?
Yeah.
WebMD.
So I think that if when you're seeing a patient, if you ignore that and try to just tell the patient, well, forget about that. In fact, don't even bring it up and just talk about the surgical options. I think that you don't really give the patient true informed consent. I think you've got to talk as a surgeon about the less invasive procedures and be willing to go to bat for the patient if that's what they want. Because ultimately the patient is the consumer,
Sure.
We're not treating the surgeon, we're treating what the patient would like. And I think my job is to educate the patient and then let him make this decision about what procedure he wants done, where he wants it done, which is not always at my institution, and when and whatnot. So I think it's an education process.
So, Dr. King, if we're talking a lot about the cardiac end, and I do want to ask more questions about the thoracic end of what you do, but let's standard bypass surgery. How long does a bypass surgery take?
It can take about 3 or 4 hours sometimes, Tom. It just depends on how many vessels you need to bypass. Part of course, doing the bypass operation is that you have to remove the saphenous vein from the leg. So we have a team that does that at the same time that we harvest the internal thoracic or the internal mammary artery, which is underneath the chest cavity. We harvest that. We get those all prepared before we ever go on the heart-lung machine, or even if we're doing it off pump. Some people do that. Then we have to still prepare the conduit before we're ready to actually do the procedure to sew onto the block vessels.
So can you explain to us, you hear people and it's like, hey, my grandfather or my uncle or my dad or whomever, they had a triple bypass, or they had a single bypass, or they had a double bypass. Can you explain the difference between all of those?
Well, there are three major arteries in the heart muscle. There's a left main coronary artery that branches into what we call the left anterior descending coronary artery, and then the circumflex coronary artery. Those are the two major ones on the left side. And then there's a right coronary artery as well. So, but all those three vessels have tributary vessels that come off, smaller vessels. And sometimes they're pretty large vessels. And so at the time of surgery, you may wind up doing 4, 5, 6 vessel bypass on the patient if his anatomy warrants it. On the other hand, if they just have just 3 arteries, or they have 2 arteries that are blocked, but the third one's in pretty good shape, it doesn't have a lot of blockage in, then you'd only have 2 bypasses. So the number doesn't make as much difference as how many blockages really are exist.
So what is the one that we always hear, and we'll be sitting in deer camp and it's like, hey, did you hear that so-and-so had a heart attack and they had to have bypass because it was the widowmaker?
Yes. So the widowmaker is generally the left anterior descending coronary artery that goes down the center of the heart, Tom, and it supplies the anterior wall of the heart as well as a bit of the lateral wall, the apex of the heart, and also the septum between the right ventricle and the left ventricle. And it's a major coronary artery. And if that blocks off, you can have a heart attack or an arrhythmia and death, from the heart attack. So that's why it's not a good place to have a heart attack at. No. You like to prevent that.
Okay, so we've been pretty serious here in our discussion so far, and as I opened this up, Dr. King, that you and I have known each other for a lot of years, and I happened to be in deer camp with you when you shot your first deer ever, which folks, I have to say it, we ate that deer. It was very tasty. We butchered it all ourselves, but we got a treat that night that Dr. King shot his deer, because first of all, I've never seen a person gut a deer with scalpels before, and you did a very nice job, but you also took the heart home with you.
Right.
And after dinner that night, folks, I was able to watch Dr. King do a bypass surgery on a deer heart, which was absolutely amazing. But I'll never forget what you said. And that was, you looked across the table at all of us and you said, you only wish your heart looked this good.
Yeah, that's right. Yeah. Yes. Well, of course, a deer's heart does not have any atherosclerosis or blockages, of course, in the arteries. And even in an animal, the heart is such an incredible organ. It does one thing: it pumps. And it's just so efficient. And it's just how God could design a pump that you and I were talking about artificial hearts. So we've still to this day not been able to come up with something that has anywhere near the efficiency or can last without clot problems and bleeding problems, everything, like the human heart. So, and to do a heart transplant, and to see the patient, like I said, the day after, it's just like a new lease on life. So it's just an incredible organ. So even in a deer, it's amazing.
I can tell you, I've seen that firsthand, because a good friend of mine had a heart attack and had a heart transplant and is very healthy and doing very well. And it's absolutely amazing to see somebody who had been so ill and a person who had been healthy had a heart attack, and everything went downhill so fast that to have that happen is absolutely amazing. Take a little shift here now from deer hunting and move to the thoracic part.
Yes,
Can
yes.
you explain what does that part of what you do?
Well, that's an interesting question, Tom, and it's really evolved through the years because when I trained, you were trained to be a heart surgeon as well as a lung surgeon and an esophageal surgeon, actually. We did a lot of that at Mayo. And now the programs have changed and shifted to where you can actually avoid doing general surgery, and some of these programs are very short period of time doing general surgery, and you go right into just a purely cardiac surgical fellowship. And then you have programs which are based on doing some general surgery and all just thoracic surgery, or all just lung surgery and esophageal surgery. So the two subspecialties have now coexist. They used to be one, but now the people are graduating from most of the programs these days are really they go in the direction of either doing lung surgery or being a cardiac surgeon.
So most lung surgeries, would that be more of cancer-induced type surgeries, or what kind of surgeries would we be talking about with the thoracic system?
I think lung cancer, that's probably number one. Then problems with infections that get into the chest cavity. Empyemas, that's what that's called. And then of course some young patients who actually they drop their lung or they have a spontaneous pneumothorax. That was another, when I used to do a lot of lung surgery, that's something that we treated quite often.
What is that in layman's terms?
It's where a weak spot in the lung, it just pops, and the lung is filled with air. It's just a sponge filled with air. And if the lining over the lung were to rupture, then air escapes from the lung into the chest cavity and causes the lung to collapse.
Okay. Dr. King, if you could have a preface of questions that people would come to you prior to, we talked earlier about some of the anxiousness and obviously fears of going into, what would be some good questions that a patient who's having heart issues could come to you with that helps out the whole scenario?
Well, Tom, I've never been criticized for this, but I try to ask the patients when I feel it's appropriate, about their faith, and everyone wants to know what's the risk of the surgery, and I can say, well, I think I can probably replace your valve with a 1 or 2% risk. I could probably replace your aorta with that 1 or 2% risk. I can do a bypass on you for the same risk, but it's still not zero. So even if it's 1%, what if you're the 1% who has a complication or for some reason, doesn't make it, expires, that you pass away? Well, how is it with you? I mean, are you prepared, if this is, ultimately going to be, your last day? And so I really think that my job throughout the years has been much more than just being a technical, a technician, in the sense of what surgeons do. But I felt that I also have a responsibility to the patient to holistically and globally, in a sense, care for all the needs of the patient. And many times that's physically, emotionally, and then of course spiritually. And I've had a lot of patients that I've recommended that they not have an operation for whatever reason, and I see them a lot. They'll come back and tell me, "Thank you so much for putting my life in perspective for me, just in case, I don't have another day on this earth." And so I think that you really have that kind of obligation.
That's awesome. And so you look at it from holistically from every angle for the patient. Let's talk about after. So somebody's had a bypass surgery. Now it's day one in the healing process. What is a typical, and I don't even know if that's a good word to use, but I'm going to use it anyway, a typical recovery time for somebody who's had bypass operation?
Well, I think the first week, they're generally in the hospital 4 or 5 days, Tom. And honestly, I mean, the first few days is pretty tough on the patient, I mean, whether it's they have an incision between the ribs or whether the sternum, the breastbone is opened up. I mean, it's pretty painful for the first few days. And I think that we before surgery tell the patient they're going to experience a lot of discomfort, the ICU nurses are just so excellent here that they give the patient plenty of narcotics and medication to try to alleviate the discomfort. But the first few days are tough. But actually, Tom, is as mutilating as it seems like when you open up the breastbone. But about the fifth day or whenever they're ready to go home, the pain's not too bad. And when they come back to see me in the clinic 2 weeks after their operation, very few of them complain about a lot of chest discomfort. They have a pillow actually, Tom, and they're told that whenever they cough, they should hold the pillow. And if they'll do that, that keeps the breastbone from moving at all. And, during a couple of weeks, it's not too bad. But the whole recovery, the whole healing process takes probably about 3 months, to tell the truth.
And is that whole healing then in the recovery, talking about diet, exercise, all of that? Is it a whole program together at that point?
It is. We try to go over some diet recommendations for the patient before they leave, but we also plug them into a cardiac rehab program before they leave the hospital. So it's not real strenuous, but it really helps to recondition the patient after they have a big operation like that, because they leave pretty deconditioned. So they need to be reconditioned, not just the heart, but their legs. I mean, their whole body is just, it's just, surgery is just by nature pretty catabolic experience, and it takes a lot out of anyone. And that's why they need to be educated beforehand to know that this is not going to be, I'll be out here in 2 days and feeling, like $100 I mean, it's going to be tough for a few months, but ultimately it's going to be the best thing for you.
Okay. What is the best advice you could give to all of us out there so that we never have to come and see you in a professional standpoint? What if you had to look at a couple of triggers that are probably things that cause us to end up with plaque in our vessels and create the situation where, hey, we have blockage and we may end up having to see a surgeon someday? What can we do to help us prevent that today and every day forward?
Well, I think I'd begin, Tom, by taking a very obvious one, that is, if you smoke, stop smoking. If you don't smoke, never even be lured into thinking that it's okay. Smoking is like throwing gas right on the fire for atherosclerosis. So I think smoking cessation for sure. Then I think the next thing is making sure that the patient's lipids, or someone who's trying to prevent a lot of plaque or from forming, have your lipids checked. Make sure that you don't walk around with a cholesterol of 300 and an LDL cholesterol that's 150 or something like that. So because the medications, the statins and other drugs are very helpful in trying to bring those lipid levels down to an appropriate level. And then obviously, if one check, make sure your A1C, your hemoglobin A1C is not elevated, for example, which it would be if you were a diabetic patient. Keep that under control. And hypertension, the silent killer. Make sure that you're not walking around with a blood pressure of 180 over 110, but you feel fine. But it does, it's very bad for your heart, your body in general, your kidneys, and it's something we can treat appropriately. But as I would say, the number one thing, and it really grieves me so much to see young people smoking, because when you're young, you think you're invincible, and but it's devastating. It causes such terrible inflammation to the arteries and the heart muscle, and it's the plaque forms because the arteries become scarred or damaged, and when that happens, it's a secondary phenomenon of the plaque or the cholesterol builds up on the scar that occurs, and nicotine and smoking is a great nidus for that.
In just a couple of minutes, can you tell us lipids? I'm not quite sure what you're talking about.
Well, for example, cholesterol and triglycerides, which is sugars basically. Okay. So maybe people need to be a little more active and not hang out at the fast food restaurants as much as maybe they have in the past. But
so they're not the fast food restaurants are not sponsoring your surgical team this year.
No. I probably should have my cards at some of those places, but I think But it's amazing. Eat healthy. But once again, I mean, we have patients that try to eat healthy and they don't smoke, and they still have problems with their heart. They have plaque deforms, they have heart attacks, and they come in and they say, "Geez, doc, I try to take great care of myself." And my first question is, did anybody ever check your lipids? Tom, did anybody ever tell you what your cholesterol, your triglycerides were? No. So I think, even as a teenager, certainly someone in the early 20s, have your primary care doctor run your lipid profile to see what that looks like, and then depending on what it shows, whether or not you should be on medications to adjust it properly.
Can some of that just be bad genes?
Totally. I mean, one thing about atherosclerosis that we know, if you got a bad family history, you're it's just the genetics is the one thing that we can't do anything about. We can stop smoking, we can treat your hypertension, we can keep your diabetes under control, and we certainly can lower your lipids, cholesterol and LDL cholesterol and your triglycerides with medication, but we can't do anything about the genetic factor.
Okay. So this has been just so fun to listen to, Dr. King. And folks, this is Dr. Mike King, cardiothoracic surgeon, who's been doing this for 34 years. So he knows what he's talking about. But now we're going to learn a little bit more about you. So we're going to put aside Dr. King, the surgeon. We're going to talk to Mike King here a little bit. So outside of the hospital, I know you like to travel. Favorite place to travel?
I think one of my favorite places to travel is going on safari in Africa. That was great fun. That was just great fun. My family, I did that several years ago, and I would really like one of these days to go back and to Africa again and go on safari again. It's wonderful to see the animals in their natural habitat.
You just answered my second question, because it was like, where's your bucket list travel place? It's going back where you've already been.
I haven't been to Ireland yet.
Okay.
And I'd really like to go to Ireland, because when I had my DNA tested, apparently I'm like 98% Irish. So I'd love to go and spend some time in Ireland, and I hope to do that in the near future.
Perfect. So you're mountain biking. You're bicycling.
Yeah. I used to mountain bike. Now, pretty much my wife and I just have the road bikes, but regular bicycles, of course. But we do that. We enjoy that. We do a lot of walking, and then I have another, hobby, which is really therapy for me, and that is I continue to have my horse and ride him. In fact, I rode him this morning, actually, before I came to work, so that was good. So I enjoyed that.
So do you ride your horse? And I know you've had some horses over the years. Do you ride them just kind of like mental therapy for you, or are you in competitions, or are you barrel racing, or what are you doing with the horse?
No. I'm way too old for that, and I'm not that good a rider. But I just do it really for therapy. But I think just like with the patients, when I sit down with them and I try to walk in their shoes vicariously, I think the same you can bond with an animal that way and try to learn, how they feel. And I can tell. I had this horse for like 14 years, but I know his moods, and I know, and I think animals are really, they're very therapeutic, and you can learn a lot from animals, and I certainly have found that out to be the case with my my horse. But we don't compete or anything like that. My daughter used to shoot off of him, do cowboy mounted shooting off of him, but I just go out and just ride him and have fun, and hope he has fun.
Can he tell your mood?
Yeah, I think he can. He seems to be a little more if I'm like really tired or fatigued from a lot of operating, or some patients or what that I feel really personally involved with, especially drug addictions that we see from time to time, patients that destroy their valves. It's very, very, that's very challenging, and it's takes a lot out of me dealing with those kind of patients. But yeah, I think he does. I think he seems to be a little more nurturing. He doesn't seem to be quite as prone to act up or anything. He just, today we'll have an easy day.
Exactly. So we have this quick section here, Dr. King, called the Packed. Imagine that, the Packed question segment. So these are just rapid fires. Who is your biggest role model? I think you may have touched on this, but let's hear from you.
Actually, I think my mom.
Okay.
Actually, my mom. She's a wonderful woman, you know. She taught me all the Christian virtues and everything, and showed me that, you know, your faith is so important.
Best life advice you ever received?
Be humble. Be humble. And kind. And kind.
Well, and I think you're perfect for that with the profession you have. Favorite band or artist? And I know you play the guitar too.
Yes, I do. So I like Taj Mahal and Kebbo, two great blues, you know, musicians.
Well,
and
how did
bands.
that happen? Blues from Memphis.
And many times I have seen B.B. King. He was great. He was a
Wow.
yeah.
What's your biggest fear?
My biggest fear is that any given day I haven't done my part as a human being to bring a little kindness to this world, which is in so desperately in need of some sensitivity. There's
Hallelujah.
so much anger and you know, people who just need someone to just be encouraging to them and affirming them. So that's what I try to do. Bring kindness to people each day.
And the last one is, what's your favorite movie?
Top Gun.
Ah,
Yeah.
I'm there with you, Top Gun.
Yeah. Oh, good. Top
This
Gun.
has been so fun. So, folks, this has been Dr. Mike King, cardiothoracic surgeon. Today we learned about somebody who does save lives every day and does something probably a lot more important than many of us do every day. And the word I just got from him was humble. And I've known this gentleman for many years, and humble is a great word to use for you, Mike, and for what you do and people's lives you've saved and people's lives you've made better. We can't thank you enough. Folks, this has been Dr. Mike King, cardiothoracic surgeon. I hope people learn something. I hope people learn something about themselves, how to take better care of themselves, that if we run into health issues, that there are people out there that want to help us, will be humble helping us, and make us a better person in the long run. Dr. King, thank you so much.
Thank you, Tom. Thank you. It's a pleasure talking to you
We
today.
really appreciate it. And folks, until next time, unplug from the indoors and recharge in the outdoors.